Yes, I think our HIT does have a big challenge because it's really quite a long pathway. So we're talking preconception, where women may have existing mental health problems or might have risk factors. So some kind of family history, previous history of post-traumatic stress disorder, a previous difficult birth, all sorts of things. So right through antenatal, the birth itself, the postnatal period, and technically we go up to the infant's first birthday. That's the kind of official cut-off of our pathway. The reason why it's so important, obviously the specific risk to women and babies themselves, and I'm sure most people in the room will be aware of a very recent tragic case in Bristol, which showed, just how serious this can be. But I think particularly from the research that's been done through the Children of the 90s study, has proved, I think, that not just postnatal depression, which is what most people think of, but mental health problems in the antenatal period have a demonstrable effect on the infant, child, and right through into adult mental health. I haven't got the slides for it today, but it's all available, that shows, this is something that has a long-lasting effect. So yes, some women have the baby blues and get over it, but this is an issue that can have a lasting effect. So in terms of numbers, the numbers who have the most severe, we're talking small, but as I say, potentially as bad as it can be. I think what's a bit more scary really are the quite huge, given that we have about 6,500 births in Bristol a year, we're saying that 1 in 6 women may have some kind of mild to moderate anxiety, depression, difficulty in forming a healthy relationship with their baby. And I think actually, any of us who has friends who've had children will probably recognise that it is common, and it can express itself in all sorts of different ways. There's the classic baby blues, but there's anxiety, the mum who's down at A&E every week because she just kind of worries about her baby and she can't quite settle, and obviously again the long-term impact of poor mother-baby attachment and the impact that can have on the child. So when we set up the HIT, these were our work streams, and what we were trying to do was look across that whole pathway. So starting from the universal, looking at services like children's centres, health visitors, midwives. What can we do in the wider community to strengthen, provide more support for mums, provide groups, provide advice, a recognition that this is a really common condition. It might happen to you. Normally you'll be able to get through it, but if you do need some help, this is where you can go. Looking specifically at the antenatal period, because obviously there's a time when you book for antenatal care, your midwife will ask questions about your mental health. They should also, if they can get it, review your health record, look for risks. And it's obviously in the antenatal period that a lot of problems become apparent. And so we need to have a clear pathway. Are the problems identified? Are they then risk assessed? Are women then diverted into the right source of support? Whether it's at one end, it might just be seeing the GP. It might be access to an IAPT program. If it's more severe, it might need a more high-level intervention. If women are on medication for a mental health problem, they'll need consistent and reliable advice. Is the medication safe? Will it affect my baby? Can I breastfeed on medication? Obviously, to deliver those, we need staff who are qualified, so teaching and training. Patient and public involvement, we had that as a separate work stream. We're now moving towards making sure that runs through our whole programme. And then one of our big issues locally is that we've recognised that, well, there's been for a very long time the recognition that we don't have the specialist expertise and support in place. We've got a very good mother and baby inpatient unit, New Horizons at Southmead, but that's only a 4-bed unit, and it's for the whole of the Southwest plus anywhere else that, you know, if there aren't beds elsewhere. So it's the community support. So these are the areas we've been focusing on. So we're talking about our achievements, and I think one thing to stress, and I'm sure this is the same for all the HITs, we can't take credit for everything. You know, these are not all things that we've done, but I think what the HIT does do, because we bring together a really wide range of people. So in our HIT, we've obviously got researchers, we've got clinicians going right through from health visiting midwives, obstetricians, child and adolescent mental health, infant mental health specialists, and we've also got some really good third sector involvement. So particularly Bluebell, which is a sort of a pioneering organisation that's been set up in Bristol and has been really successful in getting funding to run peer support and support groups, and is really just such a brilliant organisation. So I think you know, part of our work is around providing that sort of breeding ground. So, for example, Bluebell were able to get funding from the Wellcome Trust to make some absolutely brilliant animated films, which are basically women's own stories then animated, and they're such a great resource. You know, we had a workshop when was it, Adra? Last summer? Can't remember. Yeah, and we didn't have a service user with us in the workshop, but we started by showing one of the videos, and it was so powerful at just getting everyone in the room to kind of focus on what this actually means for a real person. So we didn't do that, we didn't fund it, but I think, you know, we helped support and we're able to use it. I think one of the things that's really good is our pilot project in children's centres. So this is something where early years colleagues from the council who manage the children's centres were saying it would be great if midwives could come into children's centres and actually maybe deliver some of their antenatal education there and support parents groups. And that's being piloted in 2 or 3 children's centres and is going really, really well. And another good example, I think, is the training course. And we're able to use people from our patient and public involvement, and they're really keen to go into training for new midwives, health visitors, etc., but also CPD and study days. And they're sort of developing the skills to make good interventions into that training. So that sort of collaboration is really good. And then I think just being ready to take opportunities. So we have been trying for years to get funding for the specialist community team. When the HIT was formed, we did a business case, didn't get through, but then circumstances changed and now we have got some funding. So, and we were ready to go. And for me, writing that business case, having just on tap the sort of the specialist expertise just made my life so much easier. And, you know, in the commissioning workshop earlier, you know, we were talking about how it's difficult to sometimes get people on board. But because we were all already signed up, you know, I could send out an email saying, I've got to do this business case, can you help? And everyone said yes, because we already had the relationship. So that was great. So I think the challenge is, again, you know, everyone said this and it affects all the HITs. How do you influence the priorities where there are major gaps? So as I say, I've probably been working on the business case for the specialist team for 8 or 9 years. And, you know, in our HIT, we're all passionate about it, but in the bigger scheme of things, how do you get that influence? And I think that is the question really that Bristol Health Partners have to address. I thought I had another challenge. I think I forgot to put it on the slide. I think the other challenge just is we're all so busy. You know, this HIT is good because it's also part of my day job. And I think for most members of the HIT, it's at least a part of their day job. Some of the other HITs that I'm engaged with are much harder because it's not part of it's not a work priority for me. So it kind of feels like it's over and above. And those are the ones that are really challenging. So is that final slide? So these are some of our funding applications, because obviously the mixture between the research and the implementation is really, really important to us. So if anyone has any questions about these, I have to ask Jonathan because I don't know the answer. And then, so our focus for the coming year, so we want to keep the universal work stream and the teaching and training going, because as I say, those are things that have worked really well. We'll carry on with the research. We need to embed our patient and public involvement. And I think as our business case for the specialist team moves to a business as usual, what I really hope we can use the HIT for is actually to support the evaluation, because again, as was said earlier, we are so bad in the NHS. We set things up and then we just don't evaluate them. And then when they're threatened, like I had on another topic, a scheme this year, where suddenly the CCG said, why are we funding this? We searched everywhere for evidence, no national evidence at all that what we were doing was effective, even though there was an organisation with the same name, like it was a national network of this particular service, and they had no evidence base, you know, and how crazy is that? So that's our hit.